soon divides into a supraorbital and a supratrochlear, one being above the orbit, the other being above the trochlea. A third component is the nasociliary. The nasociliary has a complication into the posterior ethmoidal foramen, into the sphenoidal and ethmoidal air cells. It gives off likewise a branch into the anterior ethmoidal foramen and then appears on the face below the angle of the eye here as the infratrochlear. This anterior ethmoidal nerve is known as the internal nasal, I-N-T-N, nasal, internal nasal, which runs high in the nasal cavity and finally actually expresses itself externally on the side of the nose as the external nasal, Similarly, branches from the nasociliary, called the long ciliary nerves, are purely sensory nerves and penetrate into the eye globe itself to provide general sensation to the cornea, to the iris, to the choroid, and to the ciliary body. The long ciliary nerves. Poke yourself in the eye. You're hurting through the long ciliary nerves very probably, and certainly through 5-1. It's an exquisitely sensitive area, and the 5-1 facial reflex is well known. Poke, blink. A great motor nerve also enters the superior orbital fissure, and this, of course, is the oculomotor 3. The oculomotor divides into a superior and an inferior division, and running along with the oculomotor, switching to green now, here comes parasympathetic, runs preganglionic parasympathetics, and they will follow the inferior division. Hanging off that inferior division, I don't like that green very much. Hanging off the inferior division, it looks too yellow to me. Hanging off the inferior division is a ganglion, the ciliary ganglion, where presynaptic axons synapse with postsynaptic cell bodies. And then these are carried onward as the short ciliary nerves into the globe to provide innervation to the smooth muscle here, the ciliaris muscle, so important in close focus or accommodation, as well as to the constrictor pupillae, also important in accommodation. Now, wherever you will find parasympathetics, so you also must find sympathetics. And indeed, the sympathetics, as I have told you now, gain access to the head and neck by jumping off the last of the sympathetic chain ganglia, the superior cervical sympathetic ganglion, and form a postsynaptic periarterial plexus around the internal carotid artery. A twig of this will be conveyed passing right by the ciliary ganglion, because this is, after all, has nothing to do with it, it's postsynaptic, and are conveyed in the short ciliary nerves. Likewise, these can be conveyed in the long ciliary nerves and eventually are conveyed to the dilator pupillae, the antagonist of the constrictor pupillae, as well as to other smooth muscles in the orbit and orb. Yes, Sarvanas. What? What is orange? Sympathetic. Right, orange is sympathetic. Thank you. No, you don't want to lose your colors in this game. Similarly, there is a so-called sensory root of the short ciliary nerve, which I'll put in here. Thus, you see both the long ciliary nerves and the short ciliary nerves provide sensation to the orbit. However, only the short ciliary nerves are conveying parasympathetics. A question? Yes, sir, Bob. Sure, it'll go to the dilator pupillae and other smooth, yes, right. I just didn't want to muck up the diagram. And other smooth muscles in the vasculature of the eye itself. So there you have 5-1, mostly a sensory nerve, but conveying with it parasympathetics derived from 3, and sympathetics derived from the only place in the body they can be derived, which is the superior cervical sympathetic ganglion. Okay, the motor part of 3 then goes out to innervate the levator palpebrae superioris, superior rectus, medial rectus, inferior rectus, and inferior oblique. Jimmy, speak up. No, sorry. I have labeled these diagrams using yellow in general, but when I draw a nerve, I mean motor. Sorry about that. I really ran out of colors. 5-1 is relatively simple. Yes. Yes. The short ciliary nerves provide sensation to the orbit, to the orb, to the eyeball. They provide postganglionic parasympathetics derived from 3, and also they're a conduit for the sympathetics to the eyeball. So you have blue, green, and orange. Okay? Dan. Can I hold that one for later? Because I'm telling you, I'm running behind, and because of our cutoff this afternoon, I got to get through in a certain amount of time. That's 5-1. 5-2 is a little more complicated, but involves the king of spaces, the pterygopalatine fossa. Ooh, they hate it. Everyone roundly hates this. The pterygopalatine, Professor Garricky, yeah, they hate it. The pterygopalatine fossa is a small pyramidal space behind the apex of the orbit. I have represented it here in this absolute Dadaesque fashion as the biggest thing in the head. You know, what else counts? A couple eyeballs looking there. There's a nose with a midline septum, the crista galli, a couple eyeballs, some teeth. But it really all belongs to the pterygopalatine fossa, which I've represented as an exploded room with 4 walls and many conduits. 5-2 enters here. 5-2, the great sensory nerve, and comes to the middle of this pterygopalatine fossa and then distributes in every conceivable direction as I have shown you in prosection. An anterior branch runs forward through the infraorbital fissure as the infraorbital, and thus expressed on the anterior face. A lateral branch, the zygomatic, divides and is also expressed on the lateral face as the zygomaticotemporal, and here, the zygomaticofacial. A lateral branch of this nerve passes down as the posterior superior alveolar, providing sensory innervation to the upper gums and upper molars. An inferior division courses straight down through the greater and lesser palatine canals and thus delivers sensation to the hard palate as well as to the soft. Finally, a medial division courses through the sphenopalatine foramen into the nose. It divides and runs down the midline nasal septum as the nasopalatine, eventually coming out here in the incisive canal, which some of you who are particularly pedantically inclined found, much to my great pleasure. A lateral branch, however, passes to the nasal conchae, the lateral wall. Thus it is from this one space, 5-2, controls the entire face. 5-2, however, serves as a conduit for other nervous modalities. Preganglionic parasympathetics and taste fibers are derived from cranial nerve 7, the facial. A contribution from the periarterial sympathetic plexus is added to this nerve. As we will see later, this nerve, we'll do it when we do the facial, is the greater superficial petrosal, and here the so-called deep petrosal. So this would be the greater superficial petrosal. Let's break this down. These three components run through the pterygoid canal. They are the nerve of constitute the nerve of the pterygoid canal, or the Vidian nerve. The parasympathetics emerging here, synapse in a ganglion, which is the pterygopalatine ganglion, and then are distributed in every direction to the glands in the hard and soft palate via the greater palatine, to the glands in the gums of the upper teeth, to the lacrimal gland via the infraorbital, the zygomatic, the zygomaticotemporal, and ultimately to the lacrimal. That is how parasympathetics gain tearing. Finally, to glands in the nose via the sphenopalatine foramen, following again the root of 5-2 branches. Taste, of course, can only be distributed in one area, and that, of course, is to the palate. So there are brown taste buds on the palate. And of course, sympathetics, why draw them in here? Sympathetics are going to course everywhere the parasympathetics go. Now, entering in the pterygomaxillary fissure is a great artery. This is the maxillary artery, one of the two terminal branches of the external carotid. And of course, that maxillary artery then is going to course in every single direction that 5-2 courses. And I'll just indicate these with arrows. There'll be an infraorbital, a greater palatine, a sphenopalatine. There will also be an artery of the pterygoid canal and a palatovaginal artery to the pharynx and the roof of the nasal cavity, sphenoid air sinuses. So it is, you see, ladies and gentlemen, that by understanding the central position of the pterygopalatine fossa, distributing 5-2 in 4 separate directions, distributing the parasympathetics from 7, the sympathetics from the superior cervical sympathetic ganglion, and taste fibers from 7, you can understand the whole nervous control of this area. Now, let me mark some of the distribution of 5-2, 5-1, and 5-3 on a face, because on several faces, because they are of important clinical diagnostic relevance. So if you turn to the next pages, if you are so through. You had a question, Jonathan? The maxillary artery, right up there. And that's on your sheets. Thank you for asking. Rajiv. That green object. That green object is sitting in, how would you know in an anatomic representation like this? This green object is sitting in the superolateral corner of your orbit. It's the lacrimal gland. Lacrimal gland. This ganglion, it would be the pterygopalatine ganglion. Christina. What's? Yeah, just rip right through it. Have nothing to do with it. It's not a taste ganglion. It's only a parasympathetic ganglion. Eric. The deep petrosal nerve is nothing more than that twig of the periarterial sympathetic plexus around the internal carotid that jumps onto the greater superficial petrosal nerve, and the 3 components together make the nerve of the pterygoid canal. Huh? And distribute in all directions. I just haven't just mucked up the diagram. Yeah. All right? So now turn to the next page, and you will see some diagrams on which we can mark. Jimmy. Yes. Yes? Now, bad drawing, right? Mr. Liao will let you get away with nothing. 0. Absolutely right. I rendered it incorrectly. I'm very sorry. Okay? Now, as I contemplated on page 3, these rather plain drawings of dull and ordinary faces, there occurred to me that there was indeed a face that I would very much like to draw on. And I have a rendering of a student who I think deserves it. This particular individual has subjected me to more verbal and physical abuse than any other student in the history of my 32 years in anatomical teaching. She is, in fact, the first student ever to my very face call me a badass. Now, in my youth, when I was an officer in the United States Marine Corps, I was a Bravo Alpha. There was no question about it. My men knew it. I worked them mercilessly. After all, they were United States Marines. But they would dare never to face me face to face and call me, the lieutenant or captain, a Bravo Alpha. They would be subjected to summary courts-martial for insolence and contempt. This expression of hers I regarded at the time as quintessentially characteristic of her own personal charm, although I did say to Mr. Ogami, I think that you'll remember, you must have been standing by me, I will get that woman. And so here she is in norma frontalis, Bolton the Bad. Now, and as in comparison, you see, the problem is, Chris, you sass a professor of anatomy who has also been an ex-Marine, you're just going to lose it every time, all right? So here's a rendering in norma lateralis of Eustachio Bartolomeo, the great anatomist of the 1500s. And no, they're greenish blue. You can come up and examine. Yeah, I mean, you don't want to sass me now. I mean, I'm an anatomist. I have access to 6-foot boards. You know, I could have rendered you in a full portraiture, naked, naked. I could have done this. You know, I have the capability. Don't sass the boss. All right, here we go. What you would see on this woman's face, you would see in this region, ooh, this is so fun. Wanted to do this for so long. The lacrimal gland, the lacrimal nerve, the supraorbital, the supratrochlear, the infratrochlear, and the external nasal. This is all 5-2. And so the distribution of 5-2 typically would be this. There's 5-2. And on Bartolomeo Eustachio, 5-2 is seen here. Sorry, I should have just said 5-1. I went off my rocker. We're here. Thank you. 5-1 is seen there. 5-2, let's do that on the other side, has, of course, the great infraorbital. Oh, this is so terribly disfiguring. The infraorbital and zygomatico-temporal, and here the zygomatico-facial. And so the area of 5-2 would be thusly defined. That only leaves us with 5-3, which covers the mandibular area, 5-3. And in that we have a mental nerve, the great buccal nerve. And then a nerve that extends well up into the temporal region, the auriculotemporal, 5-3. Notice that the rest of the head and neck belong to the cervical plexus, the transverse cervical, the greater auricular, the lesser occipital, and have a perfectly orderly on the back of the head dermatome metameric pattern from C2 on down. C1 has no dermal representation. She would have said, shut up and finish the diagram. No, 5-3. Ready? Here we go. Here's 5-3. It's like this. All right? Make sense? You can just test this. 5-3, 5-2, 5-1. And when we get to Dr. Shah Khoshbin next Wednesday, the great neurologist, he's going to be doing just the same thing with you. So know it. Please try to look like you've been taught something. Yes. Very good. Now, seven, the facial. The great facial nerve, you know, leaves the posterior cranial fossa via the internal acoustic meatus. Watch my lines carefully here, folks. Don't make things too fat. Keep to the right. This is a motor nerve, largely, and it comes to the medial wall of the middle ear cavity. Here's the petrous portion of the temple, a solid, almost solid block of bone, and here's the lateral wall of the middle ear cavity with the tympanic membrane in it. This motor nerve, this component of 7, then turns backward and makes another turn to run downward toward the stylomastoid foramen from which it will exit. In descending in this canal, it gives off a small branch to the stapedius muscle. Exiting from the stylomastoid foramen, the nerve will have a posterior auricular branch to small muscles, not active in everyone, but active in me. I can wiggle my ears. Of small consequence. It sends a motor branch to the stylohyoid, a motor branch to the posterior digastric, and then arborizes across the face in major branches: temporal, zygomatic, buccal, mandibular, and cervical, which of course cover all the muscles of facial expression, including the two most important ones, the orbicularis oculi, by means of which you close your eye and sweep tears across your cornea to keep it from drying out, and the orbicularis oris, by means of which you talk and keep saliva in your mouth. There is the great motor distribution of the facial nerve and all its components. However, the facial nerve has two other components, one of which is taste, brown. Taste fibers have a ganglion where the cell bodies reside, so they're bipolar. They're at the first bend, and hence its name, geniculate ganglion. Geniculate ganglion. Accompanying them will be preganglionic parasympathetic fibers, green. These two components are going to be distributed in two directions. One direction will service the upper jaw. The other direction will service the lower jaw area. Let's take the upper jaw first. An anterior branch of 7, known as the greater superficial petrosal nerve, leaves the petrous portion of the temporal and lies in the middle cranial fossa. It heads toward the pterygoid canal. It contains preganglionic parasympathetics, green, and taste fibers, brown. As I pointed out before, a twig of the periarterial sympathetic plexus that surrounds the internal carotid joins it. This is the deep petrosal. Thus is formed the nerve of the pterygoid canal, which brings it into the pterygopalatine fossa, and of course you now know that story. The fibers of taste are distributed to the palate, whereas the preganglionic parasympathetics will synapse in that pterygopalatine fossa. They'll synapse in the pterygopalatine ganglion, and they will, of course, be distributed in every direction, out to the lower teeth, forward as infraorbital. We've seen that story in the big diagram. The course of the nerve that services the lower jaw is this. It runs backward with the main motor component, and just before it leaves the stylomastoid foramen, it runs back and up and into the middle ear cavity, where it actually runs across the medial aspect of the tympanic membrane. This is the great chorda tympani, which escapes from the middle ear through an anterior canaliculus, a little canaliculus on the medial side of the sphenoid spine. Emerging in this area, out of the foramen ovale, is 5-3, which we know to be a mixed nerve, in part sensory and in part servicing all the muscles of mastication. What are they? The temporalis, the masseter, the medial pterygoid, the lateral pterygoid, the mylohyoid, the anterior belly, the digastric, and the two tensors, tensor tympani and tensor veli palatini. What's that? Huh? No, it doesn't do the buccinator. Good, I'm glad you brought that up. It does not do the buccinator. 7 does the buccinator. Bell's palsy patients, facial palsy patients have a terrible time getting the food, gets caught in the buccal recess because they haven't got a buccinator. Yeah, thanks for asking that. It's sure to come up on the final exam. Note it now. There is a nerve, one of the branches of the sensory component of 5-3 is the lingual, which is going to carry general sensation to the anterior 2/3 of the tongue. So there is the lingual nerve. But the chorda tympani is going to take advantage of this, jumping on to the lingual nerve. Along the way, there will be, yes, a submandibular ganglion. Here's the ganglion here, after which, of course, parasympathetics are postsynaptic and distribute to the submandibular, lingual, and other salivary glands. The taste, like the sensory distribution, is to the anterior 2/3 of the tongue. So there's taste. So you see that the anterior 2/3 of the tongue is serviced in terms of general sensation by 5-3, the lingual branch. Taste to the anterior 2/3 of the tongue is serviced from 7, the chorda tympani. Bacon. You bet. Vidian canal, pterygoid canal, samey same. Anna. The sympathetic? Yes, there are going to be sympathetics that will ride and will come off directly from the cervical sympathetic trunk. Right. Here's where the sympathetics get here, but this has a direct path from the trunk. 9, glossopharyngeal. The motor distribution of 9 is not particularly impressive. 9 exits, as you know, the jugular foramen and has only a single muscle to which it provides motor supply. Yellow, and that is the stylopharyngeus. Just below the exit of the jugular foramen, on the stem of the glossopharyngeal nerve, there is a ganglion. In the ganglion are, in fact, two kinds of sensory nerves. One is special sensory. These are nerves of taste, and they are distributed to the posterior 1/3 of the tongue. So the anterior 2/3 is via facial 7. The posterior 1/3 is via glossopharyngeal 9. The other half of this ganglion are nerve bodies having to do with general sensation. We're into blue now. General sensation from the pharynx the posterior 1/3 of the tongue the fauces and the soft palate. 9 is the gagger, remember? Gag reflex, that's all 9. You put your finger down your throat, you tickle the soft palate, the fauces, the back of the palate, the back of the oropharynx, and pretty soon you got a good gag going. All thanks to the glossopharyngeal nerve. Very sensitive area. These fauces, incidentally, is maybe a term that you haven't yet encountered. These are the palatoglossal and palatopharyngeal arches. And I think I've explained them before, when you look into somebody's mouth at the side, you see two Gothic-like arches, between which is protruding, if the individual is young, the palatine tonsil. So the fauces are really nothing more than folds over the palatoglossus and palatopharyngeus muscle. They create a Gothic little arch in which lives the palatine tonsil. So it's sensory to all that area, and taste also to just to the posterior third of the tongue. Special sensory branches are sent to the carotid body, which is a chemosensor, sensing PCO2, and the carotid sinus, a barosensor, pressure sensor. So that's special sensation from those two apparatuses. However, 9 also contains parasympathetics. These emerge with 9, and almost as soon as 9 passes through the jugular foramen, they decide to go back up again. and they go up through what is called an inferior tympanic canaliculus. It's just, if you look on the crest of the margin of the jugular foramen, there's a little hole there, and that's where these parasympathetics disappear. They are accompanied by sensory nerve, sensory fibers. This is the so-called Jacobson's tympanic nerve, the tympanic nerve of Jacobson. This inferior tympanic canaliculus conveys the tympanic nerve of Jacobson into the middle ear. In the middle ear, the sensory component, and I'm just going to draw this as a series of, looks like plexiform anastomoses. The sensory component extends itself from the pharyngo-tympanic tube, the auditory tube, the tuba eustachius, through the middle ear into the mastoid air cells, and is responsible for general sensation in that entire area. If your middle ear hurts, if you have a middle ear infection, you are hurting through this sensory plexus, which is the terminal distribution of the tympanic nerve of Jacobson. The preganglionic parasympathetics in the tympanic nerve of Jacobson have nothing to do with this plexus and simply pass directly through the middle ear into a small canaliculus that lets them out, these fibers, in the middle cranial fossa. And there they run forward, medial to the greater superficial petrosal nerve, which you remember is a branch of 7. They run forward medial to that, and it is called the lesser superficial petrosal. It approaches once again the third division of the trigeminal nerve, which is the maxillary division. We can mark it here as 5-3. And these preganglionic parasympathetics go through the foramen ovale, and just on the other side of the foramen ovale is the last of these 4 parasympathetic ganglia. This is the otic ganglion. There the presynaptic fibers synapse with postsynaptic bodies, and the postganglionic parasympathetics take the opportunity to ride with one of the sensory branches of 5-3. One of those sensory branches is the auriculotemporal. There it is. It happens to pass up through the parotid gland. So that is how postganglionic parasympathetics, by following the auriculotemporal, gain access and provide secretomotor innervation to the parotid. They're going silently. Finalmente, the last nerve and ironically the first great nerve that you encountered, the vagus, the vagabond, the wanderer, 10, cranial 10, saw it practically on the 2nd day of dissection, and you're still fooling around with it on practically the last. As you know, 10, along with 9, and along with the cranial and spinal components of the accessory nerve, emerges from the jugular foramen. And 10, as you know, is a giant parasympathetic nerve. So let us recognize that right away. However, hold it, cut it right there, because we don't want to interfere with this region. And we'll simply continue the vagus on its path to all cervical, thoracic, and abdominal viscera over there. Interestingly, 10 has a tiny little ganglion just below its emergence from the jugular foramen, which is a sensory ganglion, blue. Fibers pass down a tiny mastoid canaliculus and are represented, of all strange things, on a small area on the cranial surface of the auricle, the floor of the external auditory meatus, and the lateral surface of the tympanum. And this is interesting and of clinical relevance because irritation of that area, so you get a bug in the ear, something stuck in there, can give you referred pain and symptoms of a gastric nature. You can have a kid coming in, throwing up, projectile vomiting, and you look in the ear and there's stuck something in there. And you take that out and everything's fine. And you're in big money. Just remember that. Your old anatomist taught you. An odd distribution of the vagus, sensory, general sensation in that area, but there it is. Also, there's a little meningeal branch that passes up into the posterior cranial fossa, but that's the superior ganglion. Now, there's an inferior ganglion, which is much bigger. This is a big sensory ganglion, cell bodies. And this has taste. Well, it had general visceral afferent. Let me just do it this way. Hold it. Run it here. General visceral afferents from the epiglottis and, well, no, I'm going to put it this way, on the pharynx, and continuing here with the main body of the vagus, bringing general visceral afferents from larynx, cervical, thoracic, and abdominal viscera. The other half of this ganglion here has taste fibers in it. And these taste fibers are distributed simply to the base of the tongue, so-called valleculae, which are little depressions just anterior to the epiglottis. So there's a small amount of taste there. I'm just drawing in here the vocal cords. Through the superior laryngeal nerve, we provide sensation within the larynx via the internal laryngeal, which will supply the base of the epiglottis and the larynx here above the level of the vocal folds. Below the level of the vocal folds, internally in the larynx, the pathway is via the recurrent laryngeal. So there goes sensation below the level of vocal folds via the internal laryngeal. This is recurrent, right? Recurrent laryngeal. What did I say? Something else? Internal, no, recurrent. Thank you. All right, now, what we have here then is taste to a very limited area, general sensation to the middle and lower pharynx, to the larynx, both above and below the vocal folds. We have no motor representation, and that motor representation that is running with the vagus is not absolutely certain, but generally accepted to be derived from cranial 11. And so it is that cranial 11 is the motor component represented in the recurrent laryngeal nerve responsible for the innervation of all of the laryngeal muscles except the cricothyroid. And here is the cricothyroid, and it gets its innervation, again, undoubtedly from cranial 11 via the superior laryngeal, and here its external laryngeal branch thus. So the external branch here of the superior laryngeal will carry the motor fibers from cranial 11 to the cricothyroid muscle. All the other muscles of the larynx are innervated via this pathway, the recurrent laryngeal. Finally, and lastly, there is a special sensory set of branches to the carotid body, not to the sinus. There was a question. There was, you don't want to ask it. You want to ask something. Herman. This is just a meningeal branch, a sensory branch from the posterior to the posterior cranial fossa. You've got one also from 5-3 too, to the middle cranial fossa. What, please? Oh, what hole is this? This hole is the jugular foramen. Just goes right back up in through the jugular foramen, right. You see, it's jugular foramen just as 9 was represented going through the jugular foramen. Jonathan. Cranial 11. Yes, it's something that is debated. There are some papers that think there's a little vagal contribution. Most, if you look at Gray's Anatomy, most of the fibers are thought to be from cranial 11. So as not to throw you into rampant confusion, right? Although I know that you like the subtleties of uncertainty. I'm going to represent here that it is mostly 11, if not all 11, but qualify the statement, because it's not certain. No, you've got to trace, no, you have to trace those rootlets and axons right back to the central nervous system. It's not easy work to do. Lucy. Yes, special sensory. That's right. It's definitely different. It is special sensory conveying physiological information rather than general sensory information. PCO2, yes, absolutely. Right. But there's no branch apparently to the baroreceptor, just to the body. One more question and then we'll go for a break. Yes? Yes, sir. Here is the external laryngeal. Here is the internal laryngeal. The motor component that runs with the external laryngeal and provides some motor innervation to pharyngeal muscles as well as the cricothyroid is well thought to be cranial 11. Okay? All right? It's like Leon Cavallo's famous opera, Canio, Pagliacci. You know what the last lines of Pagliacci are? La commedia è finita. The comedy is over, the show is finished. Ladies and gentlemen, let's take a break, and then we will assemble here. Thank you very much. Thank you. Not necessary, not necessary. Sorry, I couldn't help myself. I planned it. Thank you, thank you, thank you, thank you. Dr. Lavares, I think, will be here shortly. You're very kind, ladies and gentlemen, and we'll stay here. We were previously going to switch over there, but we're not going to do that now in respect for those who are especially grieving today. And so we'll stay right here. And I hope Dr. Lavares got the word. I've switched him about 3 times. Sir.
This branch right here is the external laryngeal.
Right. And this one is the internal. Right.
Got it. Can I take a picture with you?
Yeah, well, yeah, you may. I don't know who wanted a picture of those drawings.
Take a picture together with Professor Jenkins. Hey, would you try and take a picture? Not over here.
Well, it's a pleasure to be here. This about, you hear me up there in the back? Yeah? As Dr. Jenkins mentioned, I'm a head and neck surgeon, so I kind of how head and neck surgeons evolve these days in the United States and most places around the world. We go to medical school, just like all of you. In fact, someone who sat there 6 or 7 years ago, who's now in our residency program, said, you know, go get some really good medical students interested in our specialty today. So, see what I can do. I hope I can do that. But anyway, we go medical school and then a year general surgery as an internship, and then an otolaryngology residency, also known as ENT. And ENT has multiple subspecialties, which include otology, pediatric otolaryngology, general otolaryngology, which is sinus work and tonsils, facial plastic and reconstructive surgery, which is cosmetic surgery of the head and neck, and reconstructive surgery of the head and neck surgery, which is what I do. And you know, I think I've got one of the best jobs in the world. Every day I get to do surgery, basically on very complicated head and neck tumors, and the head and neck anatomy, you know, if you ask me, I think is the most interesting anatomy in the body. You know, all the other guys are just cavity surgeons. They open the belly, they find the spleen, they take out the spleen. You know, we get to do really layered dissection that is unlike any other geographical area in the body. For instance, yesterday, I don't have any photos, but yesterday we had a patient, and I use this prop. Yesterday's patient had a synovial cell sarcoma here. It was about 10 centimeters. It was in the masticator space, infratemporal fossa. A component of it came under the arch of the zygoma, between the coronoid notch, to present as a parotid mass. The remaining portion of it passed inferiorly, medially, eroded some of the maxilla, and filled the buccal space with the mass. So what we did to take this tumor out, I removed temporarily the malar bone and the arch. That allowed me to get some lateral exposure. I dissected out the facial nerve, doing a lateral parotidectomy, and then basically removed the coronoid process of the mandible, and we're able to work into the masticator, infratemporal fossa spaces, and remove the tumor. The upper end of the tumor was right at foramen ovale. So, you know, with what you learn, I had the same kind of stuff you had, you know, basic anatomy, head and neck anatomy in medical school. But with what you learn here, and a little extra training, you can do, you know, sky's the limit. And I have to say that, you know, if I, and, you know, don't tell this to any of your other professors, but if I had one course, if they said, the residents call me Dr. V. Dr. V, you could have one course in medical school, what would it be? It'd be, well, the board's covered, but it'd be this stuff. Because all the other stuff I think you can learn in, you know, a month on the job training, but it's the anatomy that really matters, to me anyway. Well, post-operative management anybody can do, but the anatomy and an in-depth knowledge of anatomy starts right here. And I still remember things that I use in the OR now for head and neck surgery that I learned as a freshman medical student. So, and he didn't tell me to say any of this, okay? I said this all on my own. You're welcome. Both on and lights out. How do I do that?
What I would do is, you want probably all the way down to 3 pulse. Then you'll probably want...
It's very high tech. That's great. That one's gone. Okay, great. Great. Could you? Yeah, I'll see that clearly, right? Could you, great, separate them a little bit? Fantastic. Okay, so you already know what I do, and I gave a plug for my specialty and for this course. So what we're going to do is, but I think the best way for me to talk to you about surgical anatomy of the head and neck is to basically take you through a series of procedures that we do in head and neck surgery. Kind of illustrates what we use from your anatomy class on a day-to-day basis. Maybe you can shrink them down a little bit. There you go. Great. Then there'll be room for both of them. Thank you. Yes? The coronoid process I didn't replace. And that's not a problem. As a surgeon, you learn that there are some parts that are kind of accessories you can live without. The zygomatic arch we put back because she would have a significant cosmetic problem if we didn't do that. It is, but you know, and what we do, we alter anatomy tremendously, and we oftentimes will basically resect the muscles of mastication on one side. Fortunately, there is the other side, and these patients can actually chew very effectively with loss of all the muscles of mastication on one side. So I actually used her masseter muscle to cover an exposed mandible, which, because I'd resected a fair amount of tissue just medial to the mandible, and that will give soft tissue coverage of the bone. It'll remucosalize, and she didn't need a fancy reconstruction. We had her prepared for a free tissue transfer, a free flap reconstruction to get soft tissue coverage of that large defect. We were able to accomplish it basically with local muscle and a skin graft. She came in because she had a year ago, she developed a mass in her cheek. She had been seen by a physician who did a biopsy and found it was synovial cell sarcoma. He deemed her unresectable and sent her off for chemotherapy. She got several cycles of chemotherapy, no response to the tumor. Was sent to a radiation therapist who took a look at it and said, wow, I think this is too much tumor burden for me to be able to be effective with radiation therapy. Sent the films to my colleague, who's a radiotherapist, who sent the films to me and said, you know, what do you think? And I didn't see anything that made her unresectable. Went up to foramen ovale, but not through. So, you know, unfortunately, she is going to have all of the sensory distribution of V3 gone. But in return, she's hopefully going to be rendered disease-free. So. Okay. One of you guys up back want to quickly focus that, maybe? Oh, that's okay. So what we're going to do, the one doesn't have a focus knob on it. The left one, yeah. So what we're going to do, we're going to look at several procedures, and I think is the best way to walk you through the anatomy. Neck dissection, which is the basic, really the basic fundamental neck surgery, thyroidectomy, laryngectomies, laryngopharyngectomy, and maxillectomy, just as a means to give you kind of an insight as to what we do. Now, when we look at the neck, and we specifically as head and neck surgeons, the most common thing we have to address are the cervical lymph nodes. And the cervical lymph nodes have been designated into different regions. So the region 1 includes the submandibular and submental triangles. Region 2 includes the lymph nodes from the base of the skull, basically the jugular foramen, down to the level of the hyoid bone as they lay lateral to the jugular vein. Region 3 nodes are from the hyoid bone to where the omohyoid muscle crosses the jugular vein. Region 4 is everything inferior to that, to the clavicle. And region 5 is everything posterior to the sternocleidomastoid muscle and anterior to the trapezius in the posterior triangle. When we do a comprehensive neck dissection, what we do is encompass all lymph node groups 1 through 5, and the dissection limits are the lower border of the mandible, the trapezius, the clavicle, and essentially midline. And so we do a comprehensive dissection of all cervical lymphatics in those boundaries. Included also in a classic radical neck dissection, we take the sternocleidomastoid muscle, we take the jugular vein, and we take cranial nerve 11. And this is what you see in a classic radical neck dissection at the conclusion of the procedure. This is the right neck. Here's the lower border of the mandible. You notice there's a chunk missing because this patient had a cervical metastasis that was adherent to the lower border of the mandible. So we resected it. Here's the trapezius. You also see splenius capitis. This is the carotid artery, external, internal, the vagus nerve, the hypoglossal nerve. So this, again, is a classic radical neck dissection. This procedure was designed around the turn of the last century, I should say 2 centuries ago now, early 1900s, based basically on the basic concepts that were used for basic breast surgery or the radical mastectomy. These days, we try to save cranial nerve 11 as much as we can because there's significant morbidity from the loss of the trapezius muscle. The jugular vein and the sternocleidomastoid muscle we preserve when we can, that is, when there's not nodal disease that's adherent to either of these two structures. Modifications of the radical neck dissection I just alluded to. We try to preserve one of 3 non-lymphatic structures: the sternocleidomastoid muscle, the jugular vein, or cranial nerve 11. So that we're going to walk through now a schematic of how we do a modified radical neck dissection and a radical neck dissection. Before I do that, I want to just mention that the layers of cervical fascia, which you learn about in this class, are directly applicable to what we do when we do neck surgery, and specifically modified radical and radical neck surgery. As you remember, if these are the sternocleidomastoid muscles on either side, that investing layer of deep cervical fascia splits to invest the sternocleidomastoid muscles bilaterally, and then passes posteriorly to invest the trapezius muscle bilaterally. That is the outer envelope of a neck dissection, the investing layer of deep cervical fascia. The deep plane of dissection in a classic neck dissection is the deep layer of deep cervical fascia, or the prevertebral fascia. And a very important structure, the carotid sheath, which is formed by the condensation of all 3 layers, is an integral part of a neck dissection. In fact, since the majority of the lymph nodes are found in the carotid sheath adjacent to the jugular vein, a meticulous clean-out of the carotid sheath with preservation of the vagus, carotid, and the jugular vein when possible is the key to a neck dissection that's done effectively. The visceral compartment we usually don't touch in a standard neck dissection unless we need to get at the viscera. If we have to do a laryngectomy, if we have to do a pharyngectomy, if we have to do a thyroidectomy, then we go through that middle layer or visceral layer of cervical fascia to do what we need to do. So let's look at a classic radical neck dissection. Remember, this is going to be removal of all lymphatic groups, regions 1 through 5, the sternocleidomastoid muscle, the jugular vein, and cranial nerve 11. I think actually this schematic is going to show preservation of that. So we use initially, of course, I guess first and foremost, done under general anesthesia. Not something to be done, you know, in the office with a little local. We make an incision. This is one of many different incisions that have been designed. This one was designed by Dr. William Montgomery, who's our senior surgeon at the Mass Eye and Ear. And this allows us to get good access to the neck contents with reliable vascularity to the skin flap so it doesn't necrose postoperatively, which could lead to significant problems. So we make an incision. The flaps are elevated, which means we peel the skin flaps back. We make these flaps, elevate these flaps in what's called a subplatysmal plane. So the platysma stays with the flap. Okay, so the platysma is not left down in the patient, but platysma is going to be lifted with our skin flaps, and this improves the vascularity to the skin flap so there's not flap necrosis postoperatively. We incise this investing layer of deep cervical fascia here near the midline to give us exposure to the midline structures. When we lift this component of the flap superiorly, there's a nerve we have to protect. There's a nerve that's called the marginal mandibular branch of the facial nerve. That nerve is responsible for innervation to the depressors of the corner of the mouth. If we don't preserve that nerve, patients have trouble with drooling postoperatively. And what we learn as we develop our techniques for neck dissection is that if we take the facial vein up with some fascia, with the skin flap, the marginal mandibular nerve is protected under the vein contained within this layer of fascia. This layer of fascia is the fascia, it's the deep layer, the investing layer of deep cervical fascia that splits to also envelop the submandibular gland. So we protect that nerve as we elevate our skin flaps. Yes. Yes, I'm sorry. Unfortunately for me, there's no limit to the length of surgery that can be done. And we have gone as long as 18, 20 hours. If you design your flaps right, they do not necrose. So it's not a timing issue, it's a design issue. Yes? Mm-hmm. No, we're talking about 11, not 10. This may be it. Yeah, this is a difference in terminology. Right.
Yeah, let me just so they know. We're talking about spinal 11, which is the innovation previous spinopylonascoid. I think you were thinking of cranial 11, which some people regard isolate wrongly, whatever, that it has part of the vagus and
right.
appears in the parabaxial nerve or the radial muscle.
Right. Right. Anybody else? Okay, so that's the first step. We gain exposure, and that's true of any surgery. Step one is exposure. The next step is we're